Good evening, everyone. So, I'll just start my case presentation. This is the demographic profile. The patient is 33 years old. Occupation is software engineer. Martial status is married. Her chief complaints are multiple joint pain since 2 years. Worsened last 1 year. The patient has the early morning stiffness lasts for 2 hours. Then that her aerial activities are very difficult, like squatting, walking, and get out from the chair. And also her low back pain has developed since 3 months, but there is not aggravated. There is no weakness, no numbness. During some spinal extension exercises, the patient feels some comfortable to get relief from the back pain. There is a continuous pain. There is no change throughout the day and night. Her KDL was very difficult and dependency also more. I'll come to the history. In March 2023, the patient has consulted the rheumatologist at ChanRe hospital and diagnosed with rheumatoid arthritis. And doctor has started with DMRs and also referred the physiotherapy. In the physiotherapy, we had done the initial assessment, and that time there was no significant swelling and pain. According to that assessment, we had taught some of the range of motion exercises like free exercise, active assisted, some strengthening exercises. Along with that, we had taught some home programs and how to protect your joints, like what and all you have to do's and don'ts, everything we had explained the patient. But the patient was not really follow up in good. She had tried the alternate medications like Ayurvedic for 10 months. After 1 year, the patient came back to our hospital, again consult our rheumatologist. That time her was very worsened joint pains. She was almost in the wheelchair. Her pain was more in the knee and the ankle joints. So after consulting the rheumatologist, then again doctor has done some few investigation. That time her inflammatory parameters was so high. After the consultation, patient has referred to the department. This is for her X-ray. On the first visit, March 2023, her X-ray, the knee articulation surface are quite good. After the 1 year discontinuing all the medication, tried the alternative medication, the articular surface has very changed, dramatically very changes has seen. So according to that X-ray, after advised by the doctor, the patient has came to the department. We done our physiotherapy assessment. I'll move on to the physiotherapy assessment. On the observation, the type of the body belt is ectomorphic. The swelling has happened in the bilateral ankle joints. Patient had the deformities of flexion deformity in the bilateral knee joints and also tightness in hamstring as well as the quadriceps muscle. The external appliance she is using the walker. On the palpation, the tenderness was the grade 3, crepitus was present. I'll move to the examination part. Vitals are normal. As I said before, his major dominant joint involvement was the knee. So I'm taking that range of motion of the knee joint. So the normal range of motion of the knee joint is 0 to 150 degree. But in this case, already I had mentioned is the flexion deformity. So the patient range has only the 50 to 60 degree of the flexion range. Her radial difficulty in squatting and walking. Pain assessment, pain in the bilateral knee joint as well as the ankle joint. The nature of the pain was constant. Her pain scale is 8. So this is her X-ray. So what's your opinion? The patient has to go for any knee replacement, otherwise could the physio rehab will helpful for her to come out of that normal radial activities? Any?
Since you're presenting the case, I'm sure the knee replacement does not happen.
Sorry.
Yeah, I think.
Yeah, but now the major complaint for her is the range of motion is very quite less. Her knee was, the flexion is not that much good. So her major concern is the stiffness is more in the joint comparative to the strengthening program.
Yeah, I think, see, there are few things which we have to work with in these kind of x-rays. I think what we are missing is a lateral x-ray. If you have to take a lateral x-ray, because the problem is the patient has a fixed flexion deformity. When you have a fixed flexion deformity, AP view is not going to show you the true joint space. You should take a lateral x-ray. If you see the lateral x-ray, the space, bony surface is still intact. She being an younger patient, we would think twice to go for a replacement. So best is to take a chance. That's my advice, is to take a chance with physiotherapy. Do as much as possible. And the physiotherapy, if the joint is bad, is also going to help them to prepare for a joint replacement if it is required. I mean, that's something which you also have to remember, because the muscles are an essential for a successful joint replacement for it to be capable of. So you need to think from both the perspective. And what's your opinion?
Yes. So after the X-ray, after our examination, already doctor has given the note for our advice. So concentrate the range of motion, then the gait training. According to the doctor's advice, after the examination, I moved to the physiotherapy management. So our goals, there will be the two phases. One is the short term and the long term. First, our short term is the pain and swelling, then long term improve the range of motion, muscle strengthening, gait training, and reduce the dependency. So once the patient got reduced the pain and swelling, they get confident to do all the movements. So I'll come to the treatment plan. So to reduce the pain, so we usually use the pain relieving modalities like interferential therapy, ultrasound therapy, then TENS. For in this case, we had used for her for a 1 week of IFT ultrasound to reduce the pain and swelling. After that, doctor's note has given for us for the range of motion. So we had concentrate the more on that, because the patient predominantly complaint was the knee range only. For that, I had planned for the treatment plan to get the range of motion. So these are the treatment plan we usually used to get the range of motion, like the wax therapy, active exercise, active assisted, then passive range of motion exercises, then mobilization, along with the dry needling is the special. In this case, we use the dry needling also, the additional treatment plan for her. So I just explained how we will use this patient. First, we done the wax therapy. We usually do for the arthritis patients like a brushing method. So it will give the physiotherapist to do the movement very easily. It will give the assistant to do the range of motion. For that, usually we will give for the stiffness patient, will preferably first give the wax, then we'll ready the joint to move the movements. So when come to the stiffness part, mobilization technique plays a major role to get the range of motion. So mobilization is nothing but purely the movement done by the physiotherapist. It's the beyond the pain range, pain tolerance range of the patient. So we used to push the range what we wanted to get. In this case, we wanted to improve the flexion. So we are doing the flexion beyond the pain tolerance range. We usually plan for the mobilization at least the 3 rounds of the sets, the minimum the 5 to 10 movements per session. So followed by that, we will be encourage the patient to do the house program exercises. Because what happens if I do the mobilization, the range will improve for at least 5 degrees. It will be maintained by only do the house program exercise very in the correct manner. So we always used to encourage the patient to do the exercises in the home. Every 3 hours once, please keep move the joints. Don't, stillness you should be avoid for these cases. For that, encourage the patient will give the complemented of the home program exercises. As I said already, dry needling is the add-on treatment plan we done in this case, because while doing the assessment, we saw some of the trigger points over the quads and hamstrings, all those things. For that, we had done the dry needling. Sometimes we had saw in our department one patient has the elbow stiffness. We done only the mobilization. After a week, we couldn't get the good range of motion. After that, we assess once again the patient has the extensor group trigger points. After once release the trigger point, the range of motion got increased. So we are now concentrate for the trigger point along with the joint mobilization. This patient also we got the good range. So after that, mainly the gait program. So before that, we have to prepare all the muscle groups to do the gait training. So for that, we are concentrating the strengthening exercises. We taught the resisted exercise, the SLR with the weight cuffs and TheraBand, and taught the dynamic quads exercises. Then core strengthening exercise. For the few exercises I had mentioned here, pelvic bridging and unilateral pelvic bridging. Balance training, we had started patient with the unilateral standing, step up, step on, side walking. All the proprioceptive receptor exercises we had added for the balance training. Finally, we had given the gait training program to her. So this is the day 1, her the knee flexion. So hardly you can see that 50 to 60 degree of the range. After the 1 week of the reduction of pain and swelling with the pain relieving modality, after that slowly we started the mobilization with the wax therapy. After a week, we can get a 25 degree range of the best range for the flexion for this patient. Then after that, we had advised the patient to continue the physio rehab for quite a few 2 weeks to a month. The patient has doing good. The patient was in the walker. Now she can able to walk with the quadruped with the sticks. So she is doing good now. So what my take home message? Physiotherapy can be the effective treatment for the arthritis. It has to be the strengthen the muscle, improve the joint mobility as well as the joint functionality. It is a teamwork. As a rheumatologist medical care along with the physiotherapist joint care, the patient can lead the pain-free joint mobility and along with the less dependency of the work. So I would go with the teamwork. The patient will live the good life. Thank you.